Okay, hello everybody. I hope you guys had a good weekend. It's actually Sunday for me, but trying to get on top of all this stuff. I think I may have found a new way of uploading these PowerPoint, this one, and from here on I'm going to try to upload this to YouTube. So this should be a YouTube link by the time I get done with it. So today we're going to be talking about indirect calorimetry in the ventilated patient. So this is still actually chapter 10. It's the starting at page 174 in pill beans. So for today, for Tuesday, the 24th, I'm actually going to have two PowerPoints that you're going to have to go over. So this one, indirect calorimetry, and then ventilator-associated pneumonias. So those will be two separate presentations. Okay, so indirect calorimetry. I'm going to be talking about it, talking about why we use it, how it's interpreted. So these are just the objectives. Alright, so we look at indirect calorimetry to make sure that our patient is having the proper nutritional support, especially when they're on a ventilator. Okay, it's a calculation of energy expenditure. So it basically uses oxygen consumption and carbon dioxide production. Okay. And it requires very precise measurements of inspired and expired gases. So this technique is based on the theory that all energy that a person uses is derived from the oxidation of carbohydrates, fats, and proteins. And then the ratio of CO2 produced to O2 consumed is your respiratory quotient. Okay, so VCO2 over, so like a line, like a fraction, over VO2 equals RQ. Okay. As you'll be seeing here in the next coming up slides. So it basically, indirect calorimetry allows a clinician to estimate energy expenditure from these measurements of, again, oxygen consumption and carbon dioxide production. So this kind of helps us understand what can actually exacerbate respiratory related problems. So the type of nutritional support that they're getting in the hospital, whether it be in the form of TPN or tube feedings or whatever, they can look at these gases and help, with the help of pharmacy and nutrition, decide to, what's the optimal nutritional support to give them so that we can get them off the vent. So indirect calorimetries are derived again from looking at oxygen consumed, CO2 produced. It's looking, the resting energy expenditure represents the amount of calories required for a 24-hour period by the body during a non-active period. And it's expressed in units that will be kilocalories per day. So this uses the Ware equation, which you will find on page 176. It's in the text box in 176. It shows the different formulas that are used during indirect calorimetry calculations. So there's the Harris-Benedict equation. I basically want you to be aware of the name of these. These could be like trivia questions, like for Spinable. Hopefully someday we'll have Spinable again. And the Harris-Benedict equation uses the BEE, which is your basal energy expenditure. But that is generally almost impossible to get that number to obtain that number, because that is like when somebody's totally resting. I mean, even beyond resting, they're like basal, they're like doing absolutely nothing. So what they use then instead is the REE, the resting energy expenditure. So the REE is about 10% higher than the BEE. And actually Wilkins kind of goes over this a little bit too in your Wilkins textbook. So the Weir equation then is the new method for calculating the metabolic rate, with giving special reference to protein metabolism. I'm not going to ask you to know that equation. Okay, so like I said, when we're looking at the respiratory quotient, it's VCO2 divided by or over VO2. Okay, so if you actually take the numbers, the actual normal values, you will find that they equal 0.8. So again, if we look at these normal values, so VCO2 would be, a normal would be 200 mils per minute divided by 250 mils per minute of VO2, which then, if it was normal, if you take the math, you get 0.8. Okay, so that's our normal values. So we're going to look at what it means when our numbers are out of those ranges. So the normal range per se is 0.67 to 1.2, but generally 0.8 is mathematically how it works out if you take the normal units of 200 divided by 250. Okay, so it can help determine how the body is using food, how we break down or metabolize our fuel that is given, that we obtain in the form of fat, carbohydrates, and proteins. Okay, if we have a respiratory quotient of greater than or equal to 1, that indicates lipogenesis, so which is the metabolic formation of fat. So we're forming fat if our RQ is greater than or equal to 1. Some of the other RQ levels, again, 0.7, if it equals 0.7, that's when pure fats are being burned. The other one, we're forming fats, and the one greater than 1, remember. If the RQ is 1, that is when carbohydrates are being burned. Approximately 0.8 is when protein is being burned. So again, just like the last slide said, RQ levels greater than 1 are associated then with fat synthesis, so we're forming fat, and hyperventilation. And I recall that being a question on your little quiz that comes up after this. Keeping in mind a little quiz to review things that we're doing after these chapters. I'm counting them for attendance just as far as participation, because that's what they told us. We had to do some type of quiz or some type of something to kind of have like a check-in basically. And then also there's a high chance that you're going to see those questions again coming up on exams, hint hint. So with that being said, hold on one second. So you do have an exam coming up then on Wednesday, this coming Wednesday, exam 2, which is going to cover chapter 13, which we actually did right before we had to leave campus. So chapter 13 was improving oxygenation and management of ARDS. I believe I stretched that out over 2 days because that was a huge PowerPoint. Then chapter 13, rather that is chapter 13, sorry. Chapter 9 then was graphics, ventilator graphics. Chapter 10 is the previous lecture with volumetric CO2, and then this one, indirect calorimetry. And then chapter 14 is ventilator associated pneumonias. So exam 2 is going to cover this, and I will also put this out as an announcement. So Wednesday you'll have that exam. I'll probably keep it up until midnight on Wednesday, but just keep in mind taking these review questions, these 10 review questions that we're doing, would be a great study guide. Okay, so I need a bigger desk. Alright, so again, RQ levels greater than 1 can be associated with fat synthesis and hyperventilation. If its RQ is less than 0.7, these are associated with ketosis, so basically the breakdown of fat, which leads to ketones that can be found in your urine. Okay, so a diabetic ketoacidosis, they can have ketones in their urine. Excuse me, I'm hitting my hand. An RQ of 0.8 would normally indicate mixed fuel substrate utilization in an adequately fed patient. So that would actually be an okay level. Alright. Looking at things that are going to affect the metabolic rate. Okay, and so many different factors, including the type and rate of nutrition that is being ingested. So rate being mean whether it's given IV or if it's given through tube feeding. The time of the day the measurement is being made when they're measuring these gases. The patient's level of activity, whether they're recovering from an infection, surgery, or trauma. So if they have a fever, obviously that's going to influence it. Whether or not they have different types of diseases, especially chronic GI issues, which is probably going to definitely affect their absorption, hepatic and renal and endocrine, because it's going to depend on how well they filter and absorb, again, nutrients. Cardiovascular and pulmonary diseases can also affect the metabolic rate. So body temperature changes with different bacterial or viral infections can also affect the metabolic rate. Keeping in mind that with an increase of body temperature of 1 degree Celsius can actually increase the metabolic rate by 10%. And I found this to be pretty interesting here, this next statement, that burns, long bone fractures, and surgery can actually increase the metabolic rate as much as 200%. That's crazy. So the resting energy expenditure and the RQ is going to help advising how they should modify the nutritional support and help guide us to hopefully manage these patients on vents and help us get them off the ventilators. So we have to remember that malnutrition is very common for patients with chronic lung disease. They use a lot of their calories just to breathe. Use of excess calories mainly from glucose. This can actually cause hypercapnia to get worse. So if they're getting most of their calories from simple carbohydrates, that can actually lead to increased CO2 production, which makes it more difficult for them to breathe. It can make it more difficult for them to get off the ventilator. So we need to make sure that they're getting the proper nutrition so that they can be successfully weaned. Knowing and measuring oxygen consumption then is helpful for successful weaning. So we have to see if they're going to obviously probably have an increased demand during spontaneous ventilation depending on how sick they are. We also have to be mindful, even if they're not on a vent, if they're on a high flow device, they need to be switched to some type of high flow device to meet their respiratory demands because their oxygen consumption is going to go up. They may even need to be a non-invasive or CPAP. post-extubation to help get them through that part. So this is a picture of a metabolic cart that's kind of like a standalone that they can do right at the bedside. They're using like a hood device to be able to obtain those gas measurements. Some ventilators actually have it built in, a calorimeter built into their units. So all of this helps to provide nutritional support, understand their metabolic function, metabolic disorders. We need to kind of understand all this so that we can best approach the needs of the patient, respiratory physiology, and it's a team approach. Again, it's looking at the physician being involved, nutritionists, or a registered dietitian, pharmacy. I know they mix up the TPN by guidance of, I think, the nutrition team, and then of course respiratory. Like I said, I don't know if I'm sure I told you guys this before, but when I worked in Madison, Wisconsin years ago, they actually did this on all their TLC patients in the Trauma Life Center. They had a canister that was attached to the expiratory part of the ventilator. That's where all the exhaled gases went. And it was like this aluminum canister that was actually mounted on the vent. And they had a sample line that would get those gases and then put it back to the mass spectrometer that actually gave us all these values that we needed. And then we went ahead and put them into a computer, or these small little calculators that we had, and they would give us like the RQ, it would give us the oxygen consumption, the CO2 production, the oxygen delivery. It was pretty cool, and they would use those numbers in rounds to adjust their nutrition. Alright, so some of the difficult aspects of using this, obviously patient interface, especially if the person wasn't on a vent. Elevated oxygen concentrations are going to skew your numbers. The higher amount of oxygen you're on, the less reliable. A higher minute volume also makes it less reliable. And then hopefully having ventilators that either have it built on board on their software, if it's something you have to connect to it. So different variables lead to accurate measurement. We need to make sure your oxygen levels are stable, being able to make sure you have a separation of inspired and expired gases, making sure you have complete collection of expired gases. So there's kind of like, trying to figure out how much time. It's kind of debatable on how much time is needed to look at that steady state, is whether or not they've collected what they needed. Handling of water vapor, because that's going to throw off your numbers, and making sure that the unit's calibrated. So you have a higher chance of error as your FiO2 approaches 100%. So a 1% error in FiO2 of 40% will result in a 15% error in so if you have a 1% error in the FiO2 at 40%, you'll result in a 15% error in your oxygen consumption. So just that little bit of variance in your FiO2 measurement can actually affect your oxygen consumption measurement. It says that some studies have shown that some systems may not provide accurate measurements and reproducible VO2 measurements for patients on FiO2 of greater than 50%. So keeping that in mind. Again, the greater the minute volume, the greater FiO2 instability. Vent dysynchrony can lead to FiO2 variability, and high levels of PEEP will also worsen, so greater than 12. They recommend that you use a dry humidification chamber between the vent outlet and the humidifier. The dry chamber will act as an inspiratory mixing chamber and actually reduce your FiO2 instability. So if you can do this dry, because the water is going to lead to errors. Other things to keep in mind, this cannot be performed on patients post-op patients cannot be formed until the anesthetic gases are eliminated from their systems. Nitrous oxide actually can diffuse into the endotracheal cuffs. Other gases other than, N2O2 and CO2 are present, and there is an error. And these gases should hopefully be kind of eliminated within 4 hours. So again, you need to make sure you've separated your inspiratory and expiratory gases. Make sure the addition of one-way valves does not affect their work of breathing, because those valves can definitely, they get sticky or whatever. So the valves, to make sure that the gases are going in certain chambers, to make sure that they're working well. Active exhalation valve can actually affect accuracy because it's staying open. Making sure a patient can inhale or exhale during a ventilator breath. This also, though, can increase patient comfort, but causes confusion to the calorimeter. You also have to be mindful of leaks. So the system must be free of leaks. All expired gases need to be collected. Loss of gas to the environment, so if you have a leak, obviously it's going to cause an error. Making sure your ET tube cuff doesn't have any leaks. Making sure your chest tube doesn't have any leaks, that there's not bronchopleural fistulas. So decreases in minute volume and fractional expired CO2 can underestimate your oxygen consumption, your CO2 production, and your resting energy expenditure. Okay, so I do believe I mentioned this before when we're performing the energy expenditure measurement. The resting energy expenditure is when the patient is lying in bed, awake, and aware of their surroundings. So that's going to be 10% higher than your BEE. And sometimes this is hard to achieve with ICU patients. So when they're doing this, they actually want the nutrition to be put on hold. So turn off the drip or hold the drip. Want to make sure that there's no real interaction going on between the patient or the caregivers and the visitors, because you just kind of want them to be chilled out, because these interactions are going to cause alterations in your numbers, and this would underscore then the importance of the respiratory therapist making these measurements. So just try to have them quiet, limit any interactions. Other things to consider, things that might affect the accuracy, would be blood filtration, obviously avoiding hemodialysis, because the filtrations actually will remove the CO2, which then will result in inaccurate RQ and underestimates your energy expenditure measurement. Hyperventilation can also alter this. Body stores of approximately 16,000 mils of CO2. Of that, 13,000 mils is present in your bones versus what is stored elsewhere. I thought that's kind of an impressive number. This reservoir of CO2 can be tapped during hyperventilation. So you want to wait 2 hours after making any changes in your minute ventilation if you're going to obtain these measurements. Accurate resting and energy expenditure is vital to avoid feeding associated adverse effects. So we want to make sure that we're not overfeeding or underfeeding. Okay, so that's why we're getting these measurements, to make sure we're getting the proper nutrition. So underfeeding then is going to obviously develop malnutrition, and it's going to delay things and affect things such as wound healing. It can compromise their immune system, so they could have increased infectious complications. It's going to affect duration of mechanical ventilation, making it longer and resulting in longer ICU stays rather. Overfeeding, on the other hand, is going to lead to hyperglycemia, hepatic dysfunction, obviously prolonged duration of mechanical ventilation. So on one side they're going to be too weak, and on the other side, if you overfeed them, their CO2 levels are probably going to be higher, which can then lead to difficult weaning. Also overfeeding overall, depending on the source, they can become hypervolemic, having too much fluid, so they can get fluid overload, which then is going to lead to pulmonary edema and CHF. So these are all things to consider after the patient's been on the vent probably longer than 4 or 5 days, especially a week if they haven't addressed these nutritional aspects. Alright, so if we get RQs of less than 0.85, we're looking at underfeeding. If we have an RQ greater than 1, that is overfeeding and probably forming fat. So if it's in between that 0.85, that middle range, and 0.9, then they're saying that that's probably an appropriate level. So how long to measure? Okay, short answer is long enough to obtain accurate or correct values. So we want to measure until the desired state is achieved. So it just depends. On some patients it's greater than 15 minutes, or other patients it might be several hours. So really the goal is to get a steady state for about 10 to 15 minutes. In recent years, the idea of abbreviated metabolic measurements had been advanced, so we're not having to take up to hours to do this. Some have said that a steady state of 5 minutes is sufficient to get a good reading or a good picture of what's going on. Others say 30 minutes to 2 hours, but that 10 to 15 minutes seems to be kind of a recommended number. So how often do we do this on patients? Most patients have about a 5 to 15% day-to-day REE variation. So depending on what's going on with them, you have some days where it's higher, some days where it's lower, depending on what's going on. I'm sure fever or where they are in their illness. So on unstable patients, they're saying about 2 to 3 times per week, and they're defining unstable patients as patients that are spiking fevers, that are hemodynamically unstable, or possibly in the immediate post-op patients, because they're going through a lot of healing and a lot of different metabolic changes going on. Stable patients, they can do it weekly. So, indirect calorimetry is a valuable tool to help assess energy expenditure in our ICU patients. Ventilated patients have complex metabolic variations that make nutritional requirements difficult to predict. Providing this optimal nutrition can have significant clinical impact in critically ill mechanically ventilated patients. So it's important to have this addressed so we can get these patients off the vent. We want to make sure that we are slowing down or reversing any muscle catabolism. It can take up to 12 to 36 hours to really reflect any changes in your RQ after they've made adjustments to nutrition. And again, after it has been nutrition's been initiated, the goal then is to keep that RQ between the 0.85 and 0.95 range. So there are guidelines that the AARC has put out. AARC practice guidelines can be found on page 176 in pill beams for indirect calorimetry. And then also, if you there are also practice guidelines that are in our textbook on page 173 for transcutaneous monitoring, and I know that was addressed in our last PowerPoint. So make sure you're looking at your textbook. Thank you so much.